Welcome, everybody. It is my pleasure to moderate this first session, which is the women's block. So I'm happy that you're joining us this year as we bring you relevant, pertinent information that will directly benefit the patients that we serve. Let's address the elephant in the room. It is cold in here. Okay, you're not imagining that. But I hope you're sitting next to somebody you like. See if you may have to cozy up next to them a little bit closer. But hopefully as more people come in, we can generate some heat and it'll get a little bit warmer. It really is appropriate that we begin this talk and block because this is the first day of Women's History Month. So how appropriate is it for us to have the women's block, and I have the distinct pleasure of introducing a full panel of women on this team who are phenomenal and caring and compassionate, and certainly treat every patient as if they are the most important person in the world. So I will introduce our first two speakers who will tackle the infertility portion of this, addressing fertility preservation and the inequity associated with that, and allow them to speak. And then I'll introduce our second two speakers who are really great support staff, which we certainly need as a part of manifesting and accomplishing team-based approach. So I will first introduce you to Dr. Loch. Dr. Loch, I've had the pleasure of working with since I came to LSU several years ago, but she is a graduate of Virginia Commonwealth University. She went to medical school at St. George's University. She did her residency at the University of Virginia and her hematology oncology fellowship and a Master of Arts in Clinical Investigation at Boston University. And she finally came south, got tired of all that snow. She has been at LSU for 12 years, treating women's cancers, and has research interests in healthcare disparities, clinical trials, access to care, symptom control, quality of life, and heads our survivorship program. Her practice supplies multidisciplinary care to all her patients. She is a PI on a number of clinical trials, has made available numerous trials to our population. She serves nationally on the NRG, Cervical Cancer Committee, and on a number of SWOG committees. And this is all to push inclusiveness in clinical trial development. So please welcome Dr. Loch. And while she's coming up, I will also introduce Dr. Amelia Jernigan, who will follow Dr. Loch. If you don't know Dr. Jernigan, I don't know where you've been. So she is a gynecologic oncologist at LSU. Just an all-around great clinician, wonderful person, delivers compassionate care in the most difficult of circumstances. She completed her OB/GYN residency at Johns Hopkins in Baltimore, and she did a fellowship in gynecologic oncology at Cleveland Clinic. It's amazing how you all went up there and, yeah. It's nice, thank you. She specializes in the use of surgery and chemotherapy to treat gynecological cancers that require very complex surgeries. She is a fellow of the American College of Obstetrics and Gynecology, board certified. She's an active member of Everything GYN and serves on several committees. She has published and presented dozens of papers and abstracts and articles over several years, and actively involved in ongoing research. She always wants to advance the care and treatment options available to women. So please welcome Dr. Jernigan, who will follow Dr. Loch.
Thank you for the kind introduction. I appreciate it, and I hope you all have coffee enough to get through the first talk of the session. So I'll talk about fertility after breast cancer and just touch base on some things. Dr. Jernigan will also help solidify some of the overlapping information that we have. And I'll try to keep you on track. So just some disclosures. I do some consulting work for AstraZeneca, but nothing that should impact the content of this talk. So to put it in context, many of our women, now that breast cancer patients are surviving a long period of time, and not just breast cancer patients, but we've made strides in other cancers, we're starting to look at what affects their quality of life going forward. And so many of our patients, as we all know, are getting younger and younger, and these survivors, as they survive their breast cancer and their treatments, they want to go on living their lives, which includes desiring pregnancy. Retrospective data have shown that pregnancy after breast cancer does not worsen cancer-related outcomes for all hormone receptor or subtypes. Chemotherapy, surgery, and radiation can all impact your fertility. And for breast cancer, if you're hormone receptor positive, as you know, we put you on 5 to 10 years of adjuvant endocrine therapy, which you can't get pregnant on, so that further draws out the timeline. And we know one of the biggest risks for loss of fertility is aging. So there have been earlier works looking at how patients feel about this. So this is from a web-based survey of patients discussing whether or not women felt concerned about their fertility after a breast cancer diagnosis. 57% of women were concerned about their fertility, but only 29% of women reported that their fertility concerns, 29% reported that fertility concerns influenced their treatment decisions. In discussion with their providers, only 68% of women recall that there was discussion about whether or not this would impact their menopause or regaining of their menses. And 34% of women recalled having discussions of infertility risk with their providers prior to treatment. So as this has been realized and becoming more important, ASCO guidelines tells us as practitioners we need to discuss fertility and the desire for fertility before we start patients on treatment and communicate this with our patients. Patients at risk for treatment-induced infertility need to be given this information and what their risk is. Not everybody who gets chemotherapy will never be able to have a child, so there's a graded risk and how we determine that. And to be able to refer patients to specialists in the area so that they can seek counseling for different means of fertility preservation, and in a timely fashion if treatment needs to be started right away, as in breast cancer or other cancers. Some fertility options, I'll just put in a little plug for men, since a lot of people treat other cancers. This mainly focuses on women's cancers, but there is sperm cryopreservation available to males facing chemotherapy. It's a lot less expensive, and it's a lot less cumbersome for the male patient to do sperm cryopreservation, but knowing what those resources are for your patients is important, and where to send them. For females, we have, and I'll get into it a little bit, and Dr. Jernigan also is going to discuss embryo cryopreservation, conservative gynecologic surgery, if that's the type of cancer we're discussing, placing the ovaries outside of the radiation field, if that's going to be involved. Again, that's not necessarily related to breast cancer, and there are some other fertility measures that reproductive endocrinologists can help guide the patients through. So what is the risk? Anything that affects the primordial follicles, affects any kind of hormone balance that will allow you to conceive, and anything obviously that removes the organs necessary for childbearing. So how do we assess this as providers in the oncology clinic and not as reproductive endocrinologists or gynecologists? Chemotherapy related amenorrhea is not necessarily a marker for whether or not you're going to remain or be infertile. Resumption of menses is also not a surefire indicator that you will be able to achieve pregnancy. So it's a multidisciplinary management of the patient, but you as the oncology provider should have an understanding of what can impact that. So chemotherapeutic agents obviously can lower it to different degrees. Alkylating agents are the most toxic. We do use those in breast and GYN cancers. Cumulative dose of chemotherapy is important, and when you start adding agents, understanding those risks. Radiation to the localized area where pregnancy occurs is obviously an issue, and any surgical removing. So, sorry, this overlap, but these are possible mechanisms to get into more nitty-gritty about how ovarian reserve is decreased. Chemotherapy can increase apoptosis, which affects the follicles. There can be DNA damage and disrupted vascularizations. These are all theorized as to why we're causing them. Sorry, the slides are overlapping a little bit, but as we age, so while we do have younger patients who are diagnosed with cancer, often they're in their late 30s and early 40s, and as we age, the decline of oocytes occurs, so you're also fighting that battle in addition to your treatment relation. So the risk of amenorrhea, which we're using as a surrogate and often really shouldn't, but it's what we have to go by for some of these older studies, that risk is markedly increased as the age of the patient is increased. So this is something that I find helpful if you are interested in what agents cause what risk and how you counsel your patients. So for the hematologic malignancies, those have the greatest risk of causing infertility for patients. And of note, a lot of the pediatric cancers are exposed to these regimens in pediatric leukemias and such. So it's not just adults that have to have this conversation or think about these things, but the pediatric hematologist, oncologist as well. Breast cancer treatments are in the intermediate range, so they can cause it, so you do have to think of things. But as I'll show you at the last slide, it's not an end-all, be-all, which often some patients do think. So risk of chemotherapy-related amenorrhea, this is a study that they did sort of trying to look at it, and you can see from this chart that as the patient's age increases, their risk with chemotherapy. And these are some standard chemotherapies. When this study was done, we were just doing AC. CMF is more toxic to the ovaries than AC. And later on, they took a look at agents that we're using now. Interestingly, tamoxifen in this study left a higher risk of amenorrhea for patients. Chemotherapy-related amenorrhea is what CRA stands for, and age at diagnosis. When they teased out the tamoxifen, its age was the main driving factor in this study. So what about the newer agents that we're using? This is chemotherapy that we've been using for a long period of time, and now we're using other targeted agents and immunotherapy. And what is that risk? We don't really know yet. So, things are evolving, and there's some theories as to how immunotherapy can affect ovarian function, but that's something we have to pay attention to and have longitudinal studies telling us so we can inform patients of their risk. Endocrine therapy doesn't impact menses permanently. It is the duration while the patient is on the agent, even though tamoxifen can increase the risk of amenorrhea down the line. It's usually for the older patient, but if we're putting people on endocrine therapy for 5 to 10 years and telling them they can't get pregnant during that time, that alone will significantly impact fertility. Issues for women who are premenopausal, so you get your period back. Does that automatically mean that you're going to get pregnant? Anybody who's in the room who has tried to get pregnant and can't, and they still get periods, then they understand that that doesn't mean you're automatically fertile. So will they have early menopause? Will their resumption of menses mean they're fertile? So what are the options for protecting the ovaries during our therapies? So if you're getting radiation, there can be pelvic shielding. Dr. Jernigan can move the ovaries out of the way, and conservative GYN surgeries, which she'll touch on. I'll talk a little bit about for what we can do when we give chemotherapy as surgeons or movers around of anatomical parts. There's some controversial, or not controversial, but conflicting data on the use of GnRH agonists during chemotherapy to help preserve ovaries. Cryopreservation, obviously that's going to be the most effective. Oocyte donation or donor egg, and surrogacy if needed. So the issue, I'm just touch a little bit on GnRH agonists. There have been multiple studies and meta-analyses looking at this issue. The problem is sort of the markers. So how do we determine whether or not this is effective? A lot of these studies just looked at resumption of menses and tried to look at pregnancy. This is the only study that actually looked at live birth. This is the POEMS trial, and it was a little flawed with the data just in collecting the data afterwards of the successful pregnancies. But this looked at premenopausal patients. They were ER and PR negative, because there's a lot of thought that we don't want to allow ER positive patients to get pregnant because of the rise in estrogen levels with pregnancy. And so they looked at patients with differing chemotherapy without a GnRH agonist and chemotherapy with. And so they did show that there was a higher cumulative incidence of pregnancy and incidence of survival as well with the use of GnRH agonists of goserelin. The numbers were small, but this did show a positive trend not only towards pregnancy, but possibly survival. These are a list of randomized controlled trials that look at GnRH agonists, and as you can see, a lot of the, most of the endpoints really were resumption of menses, premature ovarian failure, and the sort. Systematic reviews also looked at some of these studies, and so the ASCO guidelines for GnRH agonists, the data is conflicting. But they do recommend that you consider it in a young patient due to some of the positive data that we have out there. There are minimal side effects. If you're, not thinking about hot flashes and body aches, it's easy for us to say it's minimal side effects, but I guess you're not losing a limb. And we consider this in young women with some caveats based on the data. I won't talk too much about this, but IVF and cryopreservation of embryos is the most effective in pregnancy. We can do this before we start patients on chemotherapy. If we have to do neoadjuvant chemotherapy, a responsive reproductive endocrinologist can get your patient in and do this in about 2 weeks and get them to chemotherapy, which these days insurance takes that long to approve your regimens anyway. There's talk about doing the stimulation for ovarian stimulation. You get a lot of medications to sort of ramp up the follicles for IVF, and using agents like tamoxifen or an aromatase inhibitor can help keep those estradiol levels lower in patients who have hormone receptor positive breast cancer. So if the patient doesn't have a partner, they're young, they haven't met the person they want to have children with, and they want to just have the oocytes removed and cryopreserved, that's also an option as well. The efficacy of that is lower. There are some caveats to that as well. They're not as stable when being cryopreserved, but this is also an option for patients. There's also transposition of ovarian tissue into an alternate site. So if you think about young children who are undergoing chemotherapy and they have not started ovulating yet, this is something that's discussed as well, although not as effective either. Some alternative therapeutic approaches that we're looking at are different medications that can help to preserve the ovaries in theory. And then this is going into sort of some recent data where they're looking prospectively on what pregnancy outcomes are like in patients who've had breast cancer and who have had treatment. So I'm just looking at the time. So what is the timing of pregnancy from a breast cancer perspective? We worry about the risk of recurrence, and especially for patients who are hormone receptor positive who are sensitive to rising estrogen levels. So traditionally, we've waited until they've completed all all therapy, and that's sort of the recommendation. And if you get your standard age woman who may have been fertile before then, is certainly not going to be that way when she's 45. And the options really were cryopreservation, and the other thing we do need to talk to is cost. Probably costs about roughly $300 to cryopreserve sperm, and if you get a good deal from a provider who will comp the cost of everything from meds in this city, the lowest amount of money we're talking for ovarian harvesting and preparation for IVF is at least $5,000 to $6,000. And if you're talking about somebody who doesn't comp that, that's about $15,000 to $16,000 per event, per one cryopreservation retrieval. So if you have to go through it multiple times, you can just do the math. So we have to think of ways in which we're able to provide patients the opportunity to achieve pregnancy and be brave enough to do studies where we look to do that in patients that we worry about risk. So as was stated, there's no data to support that there's harm in pregnancy after breast cancer. There's no evidence for increased risk of disease recurrence so far with the data that we have for the methods for fertility preservation. So there's a lot of concern that stimulating them down the line will increase their risk of recurrence, but we don't have that long-term data yet. Aside from genetic syndromes and in utero exposure to chemotherapy, which, by the way, we give chemotherapy to patients who are pregnant and they still have healthy babies as well. So just because you have chemotherapy doesn't mean you'll have an issue. And so these are all reasons why what we take into consideration for the timing of pregnancy. So this is just looking at the annual hazard rates of breast cancer recurrence for most types of breast cancer. The highest risk of recurrence is in the first 2 years after their diagnosis. Hormone receptor positive breast cancer patients can persist for some time, but that highest peak is 2 years. So that sort of laid the foundation for this trial that was presented at San Antonio last year called the POSITIVE trial. This was a single-arm trial looking at patients under 42 who had received treatment for breast cancer, chemotherapy, not chemotherapy, who were hormone receptor positive, so this high-risk group that people are afraid to take a look at. And this was the first study to sort of look at this. They have a number of endpoints, including breast cancer-free interval, and their secondary endpoints are looking at pregnancy, breastfeeding, offspring outcomes, the use of assisted reproductive technology, adherence after they go back to the trial, and disease-free interval. So this was the trial. Patients from 18, so after they've received their chemotherapy, if they were going to get it, after 18 to 30 months of endocrine therapy, they were allowed to stop their endocrine therapy. These are patients who desired pregnancy. They were given up to 2 years to conceive, attempt pregnancy, deliver, and breastfeed if they chose, and then go back on their endocrine therapy. If no pregnancy within the first year, they were encouraged to seek fertility assessments. Endocrine resumption was strongly encouraged for patients and to plan 5 to 10 years. And then these patients will be followed longitudinally to see a number of these outcomes. They used the soft and text data on the use of endocrine therapy as their historical control, since this was a single-arm trial, and comparing those to those patient populations, there was no difference in breast cancer-free interval or distance relapse-free interval when using this in the short-term follow-up. Also, in conclusion, so temporary interruption of endocrine therapy at these time points did not impact short-term outcomes. 74% of women had at least one pregnancy, and most within 2 years. The birth defects were low and not clearly associated with treatment, and they have longer follow-up. This year at San Antonio, they presented the same trial, but they were looking at the risk with assisted reproductive technology and menstruation recovery. Same trial design, obviously it's the same trial, these are just different endpoints. So when they looked at menses resumption, most patients, so this here, the 90% is patients who didn't get anything for their breast cancer. 85% had chemotherapy as well as a GnRH agonist, so they're also looking at this question prospectively. And then this was chemotherapy without a GnRH agonist. So still a good number of patients within 6 months resumed menses, but as you can see, those differ based on intervention. Time to pregnancy, the biggest indicator here was age, and most patients achieved pregnancy that we're going to by 24 months. So here they looked at ovarian stimulation for standard, and they broke it down a little bit more to what type of stimulation. Did they have assisted reproductive technology for IVF? Did they go through other standard things like introduction of sperm into the uterus, et cetera, that didn't utilize the hormones that they do for IVF? And those patients and their breast cancer outcomes with or without preservation were the same. Also with just stimulation and not preservation, even though the hormones are the same. So in conclusion, this is the largest prospective study investigating fertility preservation and assisted reproductive technology in patients with early hormone receptor positive breast cancer who desired pregnancy. Greater than 90% of women presenting with amenorrhea resumed their menses during the course of this study, and usually within the first 6 months. Young age was the main factor associated with shorter time to pregnancy, whereas endocrine therapy was not. So just to wrap up, some last thoughts. When you're seeing your patient, again, assess their desire for fertility preservation. Even if they're on the fence, have them see a reproductive endocrinologist. Dr. Jernigan will talk a little bit about access in the state of Louisiana now for that, because a lot of issues have been with coverage, and lots of insurance coverage don't feel like it's a necessary item to cover fertility preservation. There was no increase in breast cancer events in the short-term follow-up, and long-term follow-up will be seen. So this should be considered in patients who desire pregnancy and who have had 2 years of their adjuvant endocrine therapy, if that's what they choose. So data are emerging for ways to make pregnancy more possible. Current legislation in this state and others may impact that, so we have to be aware and advocate for these for our patients. We need to have it more accessible and financially feasible for women to be able to achieve this goal and have those conversations with your patients. This is just to wrap it up, but these twins were from my patient who thought she couldn't get pregnant. And she went to a local OB when her pregnancy test, when she was feeling poorly. This was 6 months after her chemotherapy for triple-negative breast cancer. Her local OB told her that she should terminate the pregnancy because she had chemotherapy and therefore she would have children with birth defects. So luckily she called me in a panic to see if she really needed to do that, and I told her no. And then she called me in a panic a couple months later when she realized she was having 2. And so these are the product of educating your patients. She's very happy with that decision, although they still blame me for being the reason that they got pregnant because they didn't know they could get pregnant. So you should probably also tell them too that chemotherapy doesn't mean they're not going to get pregnant. It's not birth control. And this was just another patient, and they're slowly starting to come in, so I just don't have all the pictures. So please consider this when talking with your patients, on top of all the other considerations when starting patients for breast cancer. So on that fact, I think I rushed through that. Do we do questions at the panel, or? Okay. Thank you.